thank you so much. Thank you, Laimani, and thanks for the whole great team. And thanks, Erbil. I reached Erbil, and I had a wonderful meeting with all of the doctors, Dr. Imad, Ibrahim, Mohammed, and all of them. It's one of the best cities I saw in my life. Although I'm Iraqi, I didn't see Dokan until this summit. So thank you so much. My talk will be about obesity and hypothyroidism, an approach of treatment. So I'm one of the obesity treating physicians at Hamad Medical Corporation. I'm a consultant and I'm a faculty member in the fellowship. I'll start with the first, So with my agenda, so I'll talk about the appetite, body weight regulation, hypothyroidism, who to blame for the weight gain, is it the obesity or the hypothyroid? The metabolic effects, as Dr. Yusuf, mashallah, he gave us a great lecture. However, I'll just add some points. Medical and or surgical weight loss, and we will take a home message. What's appetite? It's the desire to eat, felt as hunger, in order to meet our daily requirements for homeostasis of the body and the metabolic needs. The regulation of the weight is happened through a complex interplay between the CNS, our brain, our GIT system, and the adipose tissue. Obesity is a complex, long-life disease influenced by many factors, but its main pathophysiology is the presence of excess fat in the body. And now we are having very high prevalence, 988 million persons living with obesity around the world. What's the lipotoxicity? That's why we are afraid of toxicity of this excess fat, because it's accumulated around a major organ, that's vital organ. First in the liver, end up with NASH and cirrhosis, which is now the main reason behind end-stage liver disease in the world. Cardiac muscle, yes, and we had many cases of heart failure with preserved ejection fraction, other organs ending up with insulin resistance and type 2 diabetes. Let's go to the level of the brain, at the level of the hypothalamus and arcuate nucleus. I don't have a pointer. However, you can see that we have an orexigenic pathway and orexigenic pathway. Its main stimulant is the stomach. When you have a stretched full stomach, we will have less powerful, the single powerful hunger hormone in the body release, which is the ghrelin from the body of the stomach. There will be stimulation of the anorexigenic pathway, giving a neurosignals to the first order neuron, then second order neuron in the brain through neurosignals, neurohormonal signals, and then there will be decrease in the appetite. We will stop the behavior of eating. While on the other side, when we have an empty stomach, we will have excessive ghrelin production, which will stimulate the orexigenic pathway, APY, agouti reverse transcriptase, and then it will work on the second order neuron. We will start looking for food and we will start the behavior of eating. This is not only the story. Our body and our appetite is really a complicated system. We have another brain working and running the show more than 70% of the time, which is the cognitive emotional brain. We eat when we have happiness, for rewarding ourselves. We eat sometimes for social habits, test availability, and that's have been studied and documented by many societies. It's not only the metabolic brain that running the show. So for the stimulation of our homeostatic eating, while we will eat, we have 3 stimulants for our brain, an orexigenic pathway, the feeling of hunger, which is to meet the metabolic need that our lungs and brain need to work on it. We are eating for pleasure. This is the hedonic system, and this is the emotional brain we have. And we are deciding to eat sometimes for no reason, which is due to certain social habits. That's why obesity definition have been changed all over the last decades, saying is that it's obesity is a disease by itself that's explained by a hypothalamic dysregulation because of problems in our satiety and hunger hormone at the level of hypothalamus. And well-recognized organizations now saying that obesity is a chronic illness that needs to be tackled and treated as early as possible. Here, I just want to say that the anorexigenic part of the brain or the center, not only affected by the first order neurons I told you about, but in addition to other hormones, which is the thyroid releasing hormone, as you see here. This is from here start the link between hypothyroidism and weight gain. we will see now. Now, the thyroid-releasing hormone have a direct anorexigenic effect on stimulating the anorexigenic center in the brain. And we know that the thyroid hormone itself can work within the hypothalamus and systemically. And everyone knows that it's the key metabolic pathway to control energy storage and expenditure. We all know the relationship between thyroid hormone and weight. So when we have hyperthyroidism, we have increment in the energy exposure and lipolysis, while in hypothyroidism, we will have the opposite. We have lipogenesis and reduced energy expenditure. The thing that I would like to emphasize is Joe is just now going to the adipocyte part of the interplay. So if we go to the fat cells, it's not like before we consider them inactive organs in the body. However, now it's considered to be a very active endocrinological organ that produces something called leptin. And the leptin hormone, it's a peptide hormone that regulates the appetite and our homeostasis in the body. And because of the obesity, we will have a leptin resistance, increment in the amount of the leptin, because we have excess fat in addition to the insulin resistance. Leptin can cross the blood-brain barrier, and in resistance, it can stimulate the orexogenic pathway, and we will have an increment in weight. Now, this is the connection, I think, between the hypothyroidism and the obesity, which when we have excessive leptin, we will have increment in the thyroid-releasing hormone at the level of the hypothalamus, because to work on the receptors, stimulating more TSH, therefore there will be less T3, T4, and hypothyroidism. Now, it's have been talked by Dr. Youssef. However, will add one of the meta-analysis over 13 years that was studying the thyroid dysfunction and its relation to the metabolic syndrome parameters. And they found a convincing evidence for a major impact of thyroid function on all of the components of the metabolic parameters, which has happened in patients with obesity. And the result they found also, they conclude that the insulin sensitivity is highest and the adverse thyroid effect on metabolic syndrome are lowest in euthyroid people. Not only this, there is a link between, there is another mechanism for obesity to induce hypothyroidism, which is the autoimmune process and even thyroid cancer. So those adipocytes can produce what's called adipokines, interleukin-6, TNF, and this material producing such a stimulant for the immune cells to accumulate, causing autoimmune thyroid disease. In addition, it can cause low grade of inflammation in the body, leading to stimulation of the immune cells, and it can lead to proliferation and promote tumorigenesis in various tissues, including thyroid tissue. That's why here the medical weight management will come. And as a physician, you are unique to deliver some kind of medical weight management for your patients. So it's a collaborative core of treating obesity. It's run through a multidisciplinary team. It should be individualized for each patient. And the main aim is to lose 5 to 10% of the body mass index. And with 5 to 10% of extra body weight loss, we will have decrement in T4 without affection of other thyroid hormone homeostasis. This is the team. If you don't have team, you don't have to think about proper, complete treatment of obesity. We are just in a visual circle to complete each other: physician, dietitian, physiologist, psychologist, and surgeon, and educators. Now, the tools we have, the most important are the motivational and behavioral therapies, the lifestyle modifications, medications, and surgery. Etiology or risk factors, we have to know that obesity either could be genetic, and this will appear from the history of the patient. If the weight gain started from 5 years old, you will know that there is a genetic polysyndromic or a single gene or syndromic obesity. Or it could be acquired secondary to medical illnesses. And now we said one of them is hypothyroidism and other endocrinological illnesses. Now, if we go to the medical endocrinological causes behind it, it will be Cushing syndrome, hypothalamic injury, hypothyroidism, growth hormone deficiencies, and problems and surgeries at the frontal lobe, which will end with the Gourmet syndrome. The assessment as the assessment of any patient in the internal medicine clinics. However, we will add more, or we consider more the weight history. We will focus also on examinations, neck and waist circumference, acanthosis nigricans, hirsutism, and so on. And we will focus on the onset of obesity. Staging, BMI, yes, body mass index is important. However, the Edmonian obesity staging is more important because it will tell us the affection of obesity on all of the medical, mental, and functional status, and will give a predictor for the mortality for the patients with obesity. Now, the labs are basic labs, but if you feel like your patient, maybe he have NASH or she has NASH, PCOS, and hirsutism, and acanthosis nigricans, then you will end up sending, like patients with excessive snoring and OSA, you will send sleep study, maybe ultrasound abdomen, and in some cases we will do body composition. Now, the collaborative goal-oriented approach of communication to elicit a behavioral change in a patient, it's the only way to open for us as a physician treating obesity a way to deliver our behavioral therapy. We use the 5 A's approach, which is ask for permission, assess patients from history and examination, advise patients on the treatments that's available and they are good for them, and in addition to agree on a plan with the patient and assist them in overcoming the obstacles. Behavioral therapy, the technique that enables an individual to recognize and understand the relationship between a stimuli and a poor outcome on our weight. And we are usually doing this during the history, actually, and during the examination. We will have some risk factors, etiologies for obesity, and we can understand the situation of the patient, so we can improve their self and situational awareness. We can empower them. And actually, the single behavioral thing I'm doing with my patient is the education about self-monitoring.
2 minutes.
Dietary modifications done usually by our great dietitians in our center. They are giving meal replacement and high protein diet, and usually they will deficit 500 to 750 calories. Physical activity also by our physiotherapists, people who are doing a great job in this, and medications. The medications used according to the societies, if the BMI more than equal to 30 or more than equal to 27 with comorbidities. If it is combined with behavioral therapy and modifications of the lifestyle, we will end up with a very great result. And you can see here in the pyramid of the obesity treatment, in the base we have the lifestyle modifications, in the middle the pharmacotherapy, and at the head of the pyramid we will have the bariatric surgery. Before starting the medications, try to stop or even manipulate medications that promote weight gain. We have weight mutual medications in certain diseases. We have also weight loss promoting medication in other diseases. Mechanism of actions, we have centrally acting anti-obesity medications, and we have peripherally acting medications. Some of them stimulating the sympathomimetic activity, some of them work on the melanocortin system. But the most important one that I want you to focus on is the GLP-1s, which is the glucose-like peptide medications, because they're centrally and peripherally acting. And actually all of the medications have been studied all over the world are effective, but the GLP are revolutionary medications for obesity, because they work on everything. They work on the central nervous system, anorexogenic pathway, and insulin sensitivity, and even on the pancreas, and improving the incretin effect. We all heard about the Lancet trial with regard to the liraglutide, Saxenda, how it reduced all the major cardiovascular risk factors. Step trial for the semaglutide from 1 to 8, in which they found that more than 15% extra body weight have been achieved, and the HbA1c were lower and lower. The American Diabetes Association changed their guidelines. They put the GLP instead of the sulfonylurea, just in order to prove my talk about. So GLP is really a revolutionary medications that's coming. The new trend, Mounjaro or the tirzepatide, approved for type 2 diabetes in the Cyprus trial. It has all of the effect of the GLP, but add to it the GIP, the glucagon insulinotropic polypeptide effect. I mean, it needs a long lecture alone. But thank goodness I just put this. And with regard to the tirzepatide, we are using it now for the treatment of obesity as Zepbound. This is the medications that have been studied in a multicentral double-blind trial. And they found that after they just put the placebo group and the tirzepatide at 5, 10, and 15 milligram, and you can see that we had more than 20% extra body weight. Bariatric surgery, meta-analysis have been conducted, and more than 28 studies have been used, and also more than 1,000 patients have been studied, and in which they found that hypothyroidism, there were decrease in the TSH level and decrease in the levothyroxine dose. In any country, we have barriers. The cost of the medications, the GLP, GIP, other medications also, maybe the availability. I'm not sure in Sulaimani or Erbil or even the north of Iraq what we have. Medical diseases that can contraindicate the use of certain medications, and also surgical contraindication for bariatric surgeries. This is the things that, yes? Yeah. So that's it. This is my wonderful team.
Yes, thank you very much.
Thank you.
Okay.
Thank you.